Good afternoon, everybody. It's nice to have you joining us for the last session of the day. Yay, you made it through. Our last session of the day is going to be by Dr. Ken McLean, who's at Baylor College of Medicine in the Texas Children's Hospital Cancer Center and Hematology Program. His presentation is going to be regarding myeloproliferative, myelodysplastic, and histiocytic disorders. For those of you who need anything, please don't hesitate to type things in the Q&A or in the chat portion. My name is Julia Mead. I'll be moderating the session for the day. And then once Dr. McLean gets done with his presentation, we will go through some of the questions in the chat. Feel free to place those in as the presentation goes through or hold them until the end. You guys are getting to be pros at this. So without much further ado, I will turn it over to Dr. McLean and see you guys on the back end.
Hello, everyone. It's a pleasure to be here to discuss the myeloproliferative, myelodysplastic, and histiocytic disorders with you. Some of my favorite diseases and some that I think present some real diagnostic challenges. And I hope by the end of this lecture, you'll see some pearls of wisdom that will help you make the diagnosis and sort through the confusing presentations and laboratory data which these present. My disclosure slide here, and some things for you to pay attention to that I've tried to highlight important things in the lecture. As with all the lectures, I'll follow the American Board of Pediatrics outline, trying to cover the basic science and pathophysiology as well as possible, along with epidemiology and risk assessment, diagnosis, management, and treatment for each of these categories of diseases. All of the diseases fall into the hematopoietic stem cell system with maturation in the various lineages, and I'll highlight certain elements of these lineages which are pathologically affected by mutations or other factors which cause particular entities. So starting off with the myeloproliferative and myelodysplastic group, the biology of the myelodysplastic syndromes is really rooted in cytogenetic abnormalities, of which monosomy 7 is the most common, followed by trisomies of 8 and 21. And sometimes you might have a patient with this myelodysplastic syndrome and trisomy 21 who doesn't look like a Down syndrome patient, but then you want to look for germline mosaicism. Further, these patients can have other chromosomal aberrations, usually at least one is structural, and these are correlated with a strong prediction of a poor outcome. These syndromes often follow chemotherapy, such as the epipedofil toxins or alkylating agents some years after the radiation, chemotherapy or radiation. And they are also part of a group of inherited bone marrow disorders and familial diseases, which I'll touch on. Specifically, the idiopathic bone marrow failure syndromes, Fanconi, dyskeratosis congenita, Down syndrome, Shwachman-Diamond, Black-Van-Diamond, are patients that you'll be following with their expected cytopenias, but then they become more cytopenic, and that's when you have to consider that they're developing a myelodysplastic syndrome within their inherited deficiency. There are also some germline mutations, RUNX1, CEBPA, and GATA2 mutations, which lead to these myelodysplastic syndromes and also to finally leukemia in some of the patients. These are rare disorders in which the number of patients is between 1 and 4 per million. They're usually within the first 7 years of life, with boys equaling girls in frequency. And the older children, upwards of 10, and the teenagers have more advanced disease and a worse outcome. So like the adults with the myelodysplastic syndromes, these are divided into a categories depending upon the percentage of peripheral and bone marrow blasts. The group called refractory cytopenia of childhood, which is often found within those inherited syndromes I just mentioned, have low peripheral blood blasts of less than 2% and low bone marrow blasts of less than 5%. When they have increasing blasts beyond that, they are known as refractory anemia with excess blast, and they typically have up to 19% in the peripheral blood and the bone marrow. A more advanced stage is called REB in transformation, in which the blasts get up to the levels found in leukemia patients, 20 to 29%. There's another category of myelodysplastic syndromes, which are include JMML, chronic myelogenous leukemia, and BCR-ABL negative CML. And I will just touch on the first of these in my lecture. And finally, there's the Down syndrome related abnormalities that are quite fascinating that lead to megakaryocytic leukemia in some cases. The diagnosis of these patients is often complicated because they come also within the context of non-heme disorders, and there are patients with chronic infections, especially parvovirus, who develop a myelodysplastic syndrome, as well as vitamin deficiencies, metabolic disorders, rheumatologic disease, and mitochondrial disorders. Included in the hematologic disorders, besides the bone marrow failure syndromes, there is severe aplastic anemia, refractory cytopenias of childhood, PNH, paroxysmal nocturnal hemoglobinuria with bone marrow failure, and some leukemia patients in their early pre-phase present with a myelodysplastic syndrome. It's also found within hemophagocytic patients and patients with autoimmune lymphoproliferative syndrome. So refractory anemia with excess blasts in children looks a lot like the adult syndrome, but unlike adults, these children may have stable counts for many, many months. And some of them can go to bone marrow transplant without having chemotherapy because of the conditioning regimen seems to stamp out the clone. Typical bone marrow findings include abnormal erythroid maturation, as seen here with this very large erythroid precursor, megaloblastic erythroid maturation with this extremely large binucleated erythroid cell here, dysplastic megakaryocytes, and neutrophils with bridging in between the nuclei. So some of these patients I mentioned have a very low level of cytopenias and blast count, and they can be observed for considerable time. If you stumble upon these patients kind of a priori as myelodysplastic syndrome, you might work backwards and see if they also have an inherited DNA repair defect. Some of these patients can be stabilized with immune suppression, which includes ATG and cyclosporin. Transfusions are needed sometimes. And for a few of them, AML therapy may be included, but again, that depends upon the percentage of blasts and the tempo of the disease. One caveat, of course, is if you're going to have a SIB donor, you want to make sure that they don't have an underlying susceptibility syndrome to transplant your patient with. Unfortunately, although bone marrow transplant is really curative, the cure for these patients, they don't do well, and that's because of transplant-related mortality and morbidity from cytopenias. So the mortality for MDS patients is 40% versus 16% for AML patients, and the overall survival is less than half of that for AML patients. As I mentioned, MDS patients can sometimes be given therapy, transplant without prior therapy, and they actually can do very well, 60 to 70% overall survival. And interestingly, those patients with more bone marrow blasts sometimes have a better survival also. Not surprisingly, long-term issues include cytopenia, secondary leukemia, and decreased growth and fertility. Among the myeloproliferative syndromes, we have a problem with a common myeloid progenitor, which leads to the abnormalities seen in the more mature lineages. So the two major ones that I will talk about today are the Down syndrome associated, which we're going to compare and contrast with megakaryocytic leukemia, and juvenile myelomonocytic leukemia, which is now classified as a myelodysplastic syndrome, which is driven by mutations that map kinase pathway. And we're going to talk about diagnosis and therapy of these. We won't speak about CML, which Dr. Brown has already covered. So for the Down syndrome patients with their germline trisomy 21, they develop a somatic GATA1 mutation in the fetal liver, which leads to abnormal megakaryocyte production and megakaryocyte abnormalities in peripheral blood and the bone marrow. This happens because in trisomy 21, there's enhanced erythroid and megakaryocyte proliferation, which sets up the background for the GATA1 mutations in the fetal liver. The problem with this syndrome is that you really can't morphologically distinguish between the blasts of megakaryocytic leukemia and the transient abnormal myeloid proliferation of Down syndrome. They both have the GATA1 mutations, which arise in the fetal liver, but the megakaryocytic leukemia requires other mutations, as listed here, which lead to the more malignant form of this transformation. This is a fairly frequent occurrence in Down syndrome patients. 10% of patients will develop the profound megakaryocytic proliferation. That's very obvious, but if you do screening and sequencing, there's probably a subset who don't manifest the profound hyperleukocytosis that makes them obvious, and up to 30% may be found with this. It's deadly, with 15% having early deaths, and we'll talk about some characteristics that outline them. The median age is quite young, less than 2 months of age, and a majority of them will have a spontaneous resolution by 3 months of age. Unfortunately, 20% go on to AML, which is 90% of the case of megakaryocytic leukemia within the first 4 years of life. So as I mentioned, the mortality is 20%, but overall survival is 80%. Many of these patients, 20% will go on to develop AML, so the event-free survival is a little lower. But fortunately, many of these patients who transform into full megakaryocytic leukemia can be salvaged. So what are the risk factors for death in these TAM patients? Premature delivery, congestive heart failure, liver failure, hyperviscosity and hyperleukocytosis, DIC, pleural and cardiac effusions, and massive organomegaly lead to the death in these patients. So there are some risk categories that were sort of cemented by the CLG study A2971, in which hepatomegaly and the other adverse features I just mentioned are categorized into various risk groups. And those patients who have maybe one or none of those risk factors have a 92% survival. If you have 2 or 3 of them, the survival drops to 77%. Those patients who have 3 or 4 or 5 of them have only about 50% survival. So as I mentioned, the blasts are indistinguishable, and you will find GATA1 mutations in both the leukemia and the transient abnormal myelopoiesis. But you look for the other mutations in addition in the AML and find the clonal proliferation that is present in the true leukemia. And also remember that these patients may develop their leukemia a year or 2 or 3 after they presented with TAM, so they bear close follow-up. The bone marrows in TAM patients can be hypo or hypercellular. And like a lot of patients with megakaryocytic abnormalities have fibrosis. There's often a low percentage of blasts in the patients, but they range from 7 to 80%. And the immunophenotype tends to be more mature than a real AML, with CD33 present on these blasts, as well as CD61, which designates a platelet lineage. So who are you going to treat? Well, a lot of these patients can be observed, but if they have the risk factors that I mentioned, then you're going to have to intervene with exchange transfusion, perhaps leukapheresis, and in some cases, low-dose cytarabine for a week or so to knock down the blast count and prevent the complications of the hyperleukocytosis. The outcomes aren't that bad, even if they do transform into megakaryocytic leukemia, because for Down syndrome, there's nearly a 90% disease-free survival, as long as they're less than 4 years of age, where you see that the event-free survival isn't so good if you're 4 or greater. So for Down syndrome patients, realize that they have a lot more AML than ALL, and the ratio of ALL to AML is around 1.7 for Down syndrome, and for non-Down syndrome patients, 6.5. The JMML is a very interesting entity, which is the result of abnormalities in the common myeloid progenitor, and just a little bit after the stem cell is constructed. And JMML is a abnormality of the RAS pathway. 90% of the patients have mutations of the RAS, RAF, MEK, and ERK pathway. So of these patients, 10 to 15% of them will have neurofibromatosis. And the NF1 patients have a biallelic deletion of the NF1 gene. And among the neurofibromatosis patients who have that deletion, there's up to a 500-fold increase to JMML. Another large group of the JMML patients will have mutations, either somatic or germline in PKPN11, with the germline mutation found in the Noonan syndrome or Leopard syndrome patients. And there's another large group with mutations of the RAS genes associated with lymphoproliferative diseases, and also with another form of the Noonan syndrome. And finally, a group of the CBL germline syndrome, which are commonly found to have JMML. Of all of these patients, about a third of them will have secondary mutations, and it leads to a worse prognosis. So Noonan syndrome is a fascinating condition with this germline PKPN11 mutation, who tend to be younger at diagnosis versus those with somatic mutations. They have a better survival. And in fact, a lot of these will have spontaneous resolution and not need a bone marrow transplant. They have polyclonal myelopoiesis and normal cytogenetics, which kind of speaks to the less serious form of this. As I mentioned, other cytogenetic abnormalities lead to a more leukemia-like phase. It's a rare condition with incidence of about 1.2 per million. And as I mentioned, tend to be quite young, with a median age of 2 years and a male predominance. JMML is not easy to diagnose because it looks like a lot of leukemias with organomegaly and fevers. But one of the unique factors is the rash that these patients have, often eczematoid, or maybe looks like xanthogranuloma or leukemia cutis. And of course, those patients with NF1 are going to have cafe au lait spots. They often have diarrhea, respiratory symptoms, and failure to thrive. They present like other leukemia patients with anemia, leukocytosis, and decreased platelets. But for the JMML patients, the important factor for you to remember is that they have a monocytosis and increased fetal hemoglobin. So the outcomes for those with the spontaneous resolution is good, but those that go on to leukemia have a worse outcome. So spontaneous resolution, as I mentioned, is typically in the Noonan syndrome patients, or males, young, have a modestly good platelet count and low adjusted fetal hemoglobin for age. The peripheral blood of these patients has increased immature myeloid cells, as shown here. They have abnormal dysplastic monocytes and increased nucleated red cells. In the bone marrow, there are collections of these immature myeloid monocytoid type cells, which are predominate, and markedly decreased numbers of megakaryocytes. There are diagnostic criteria for GMML, and you need to pay attention to these for your test. There are clinical characteristics which are important, as this does not include this BCR-ABL fusion gene. They have a monocytosis. They have a relatively low percentage of bone marrow and peripheral blood blasts. They can have massive splenomegaly and tend to be younger than 13 years of age. The mutations that are included in diagnostic criteria include those I've mentioned already, as well as some germline mutations and monosomy 7. So they're going to need one of these type of mutations. But if they don't, then they may still fit in a GMML diagnosis if they have leukocytosis greater than 10,000 and a hypersensitivity to GM-CSF in a colony growth assay. Fetal hemoglobin is increased and increased myeloid, circulating myeloid precursors. Spontaneous resolution happens for the Noonan and some of the other patients, but some of them have progression of their blasts and need to be controlled with if they have a moderate amount of blasts, sometimes with 6-MP. If an increasing number of blasts, low-dose cytarabine has been effective. And for those that are frankly developing into a real leukemia, high-dose cytarabine and fludarabine are needed prior to transplant. And unfortunately, like other myelodysplastic syndrome patients, these children don't fare well with a really very unfortunate outcome of around 50%, no matter which kind of transplant, because they have a lot of relapses. It seems that extinguishing the clone is not very effective in the majority of these patients. So the key things for you to be sure to know is the difference between JMML and CML, with the latter having a Philadelphia chromosome, presenting with priapism often and being treated with interferon or imatinib. Interestingly, there is no increased risk of other leukemias in JMML as opposed to Down syndrome patients. So move on to the histiocytic disorders now. And the histiocyte is a really archaic term, just meaning tissue cell, and the histiocytoses obviously abnormal proliferation or function of these cells. And I'm going to cover what I would consider kind of the classic background of these diseases, but as time has moved and research has shown that many of these concepts are outdated, but I will stick to the outline as you know. So first of all, the dendritic cell proliferation is what is responsible for Langerhans cell histiocytosis. And macrophage proliferation is the background for juvenile xanthogranuloma and Rosai-Dorfman. And this adult disease, Erdheim-Chester, has been packaged as a macrophage disease, and nowadays it's known as more of a dendritic cell phenomenon. And finally, the hemophagocytic syndrome. We won't consider the histiocytic malignancies today. So LCH is a disease of early of myeloid and dendritic cells, which form from the macrophage and dendritic cell lineage, which come from the bone marrow progenitors, but may also arise from fetal liver and the yolk sac. And therein lies some of the biologic differences in LCH patients, that those with skin-only disease may indeed have their abnormal cells derived from the fetal yolk sac as opposed to the bone marrow. The basis for LCH is the molecular abnormalities of the RAS pathway, specifically the BRAF gene, which has a V600E mutation. This is found in 65% of all LCH patients. Another small group have internal deletions or fusions. 15% have MAP2 kinase, and 15% are unknown. But all LCH patients have elevations of phospho-ERK. So we know that something out there is driving phospho-ERK, which leads to LCH. And I'll speak as to difference in the biology of the disease based upon some of these mutations. So like some of the other diseases, it's relatively rare. Its incidence is 5 to 8 per million, with a male-female ratio just a little over 1. These are young children typically on the average, but obviously they present from birth through adulthood. For reasons that we don't understand, it's rare in Africans and African Americans. There have been some families reported with multiple children, but this is actually a unique area of Italy that reported this, and we have not seen that in the United States or Europe and other countries. There is fascinatingly increased incidence of thyroid and autoimmune disease in these children, in these families, but again, we don't understand the meaning of that. LCH patients are divided into risk categories: high risk and low risk. And risk means risk of death, and it's based upon results of the Histiocytic Society trials years ago, in which those children who had liver, bone marrow, and spleen involvement had higher mortality than those who did not. So the multi-system patients of the low risk category are those children who have any organ system except the 3 mentioned for the high risk, and they usually include the skin, bones, lymph nodes, pituitary, but may also include the lungs and other organs. Some patients have more than one system involved, and they're called multi-system low risk, and then there are patients with just one system involved. There's another category of patients which are important to realize. They're called CNS risk, and that means risk of developing neurodegeneration or pituitary involvement. And these patients typically have lesions of the skull base, such as orbit, temporal bone, sphenoid, and mastoid, as well as pituitary involvement. So a PET scan clearly shows the difference between these patients. And this patient with a single clavicle lesion is obviously single system bone. This patient with multiple lymph nodes involved and probably some skull lesions is multifocal low risk. And then the high risk patients typically have massive hepatosplenomegaly, adenopathy, and multiple bone lesions. So histologically, you're looking for large histiocytes that have a coffee bean shaped nucleus, which stain with CD207 and CD1A, which make the diagnosis. There's nonspecific staining by S100, and sometimes FASN and factor 13A, which we more often associate with juvenile xanthid granuloma, also show a few of these cells. And in the past, electron microscopy showed us the Birbeck granules, which are found in these Langerhans cells of the skin, as well as the pathologic Langerhans cells in the disease. Presentation of these patients is highly variable, obviously, depending upon which organ systems are involved. For the high-risk patients, they present with cytopenias, and they can have a macrophage activation syndrome, which is not really HLH, but is just a macrophage proliferation because of the cytokine milieu of the LCH abnormalities. The spleen abnormalities, obviously splenomegaly with trapping of blood cells and pain, respiratory problems because of massive organomegaly of the spleen or the liver, and in the patients with hepatomegaly, jaundice, and ascites is often found. And these patients may present at birth with profound ascites. Skin rashes are so variable, they look like many of the common rashes of other pediatric patients. Oftentimes they're scaly, pruritic, and erythematous rashes, and involvement of the skin in the ear leads to an otitis externa and purulent drainage. Obviously, bone involvement can cause painful swelling, and some of these patients present with mastoiditis-like swelling and are treated with antibiotics for a good time before they're actually diagnosed. Jaw involvement is a fascinating problem in neonates in that they can have eruption of the teeth in the first few weeks of life. And if you look at x-rays of the jaw, some of the teeth seem to be floating in a pool of liquid. Lymphadenopathy is common in LCH. When lungs are involved, they present with dyspnea and may have a spontaneous pneumothorax secondary to the multiple cysts, and you'll see on chest CT that they have multiple nodules. Gastrointestinal involvement can lead to chronic diarrhea, fevers, edema, failure to thrive, and hypoalbuminemia. Endocrine system is involved in about 10 to 15% of patients, and diabetes insipidus is the presenting symptom in the majority of these, but ultimately growth hormone deficiency, hypothyroidism, hypoadrenalism, and hypogonadism are also found. There are some illustrations of the gingiva hypertrophy in a young patient with dental abnormalities, the scaly scalp rash in this patient. This child had what was thought to be a congenital viral infection, but biopsy showed this was really LCH. And this is an extraordinary psoriatic-like rash, which turned out to be LCH. These patients often have terrible ulcerative lesions in the axillae and in the genital and inguinal areas. Bone involvement classically makes a circular defect in a bone from a underlying soft tissue abnormality that may impinge on the dura, as in this case. Hypothalamic involvement can be quite dramatic, as in this patient, and also there's no posterior bright spot in this pituitary in this child who had diabetes insipidus. The neurodegenerative condition of LCH is illustrated in this patient's MRI, which shows T2 or flare enhancement in the cerebellar white matter, the pons, and the basal ganglia. So one of the striking things about LCH is that huge lytic defects can heal with therapy. And this is a patient of mine whose diagnosis was made by skin biopsy, no bone surgery was done, and healed great. Another patient had a modest sized skull defect, and the surgeon thought he needed to have clear margins and left the child with a gigantic defect that had to be corrected with a mesh. Back pain presents in patients who have the classic vertebral plana. So what are you going to do to work up these patients? The basic evaluations include a CBC. For young infants, less than 2 years of age, we do bone marrow aspirates and biopsies, or if there are cytopenias. Oftentimes these patients have isolated anemia, and if they're older than 2, we did not necessarily do a marrow. With the advent of realizing the BRAF V600 mutation is present in many of these patients, we find this in 50% of marrows which are histologically normal. Liver functions that we're going to look for are obviously elevation of the enzymes, elevation of bilirubin, as well as synthetic function. You'll evaluate for sodium homeostasis and urine osmolality for those patients with polyuria and polydipsia. And it's important to look for involvement of the peripheral blood with the BRAF mutated cells circulating, because that is oftentimes indicated of the patient who has the high-risk disease. The screening skeletal survey and chest x-ray are done for all patients. If it seems that they have an abnormal chest x-ray, or if they're less than 2 years of age, we do a chest CT because you cannot define the small cysts and nodules in the infants just by chest x-ray alone. Ultrasounds are helpful if patients have hepatomegaly, but CTs and MRIs are also used for these patients. PET CT scans are especially useful because they not only show occult lesions, which some of these other imaging modalities will not show, but also provide you with a tool to show healing after the initial therapy. We do CTs when there are specific involvement of the orbit or mastoid. And obviously, if pituitary is involved, we're going to do follow-up MRIs to follow the pituitary involvement and also looking for neurodegenerative disease later on. We've found that MRIs of the spine are actually more sensitive than PET scans for patients with vertebral involvement. And we do these, of course, for neurologic symptoms. So treatment can be widely variable for these patients. Those that have skin-only involvement, oral therapy with methotrexate or hydroxyurea is quite effective. Sometimes they require vinblastine prednisone if their ulcerative lesions don't heal adequately with oral therapy. Classically, the LCH patients have been treated with vinblastine prednisone for 12 months, and that seems to be sufficient for the low risk category. The addition of 6-MP has been used for the high-risk patients, and radiotherapy is infrequently used in children, but if there are isolated spine or femur lesions, it might be considered. The outcomes are very good for the low-risk patients if there's no mortality, but the event-free survival is not so great because of frequent relapses given the vinblastine prednisone therapy. As I mentioned, the mortality of high-risk patients is about 10%, but those patients, again, if they fail to respond to initial therapy, those are the ones that are going to be ones that ultimately fail and are about 50% of these patients are also have frequent relapses. So what are the complications of LCH? Well, neurodegeneration is certainly a terrible complication. And as I mentioned, the risk of this is among those patients who have pituitary involvement and the facial bones, as I mentioned. The pituitary involvement is very important because it has been shown that those patients who received single agent or no treatment had a 40% incidence of diabetes insipidus and more of the neurodegeneration, whereas those who received at least 6 to 12 months of vinblastine prednisone, the incidence of diabetes insipidus fell dramatically. And that is why we still include the CNS risk bones, even as a single lesion, among those who need to be treated. Neurodegeneration is something that may happen within the first 2 to 3 years after presentation, or may be a late onset problem. These patients develop ataxia, dysarthria, dysmetria, and behavior changes. And as I showed on the MRI, have the hyperintense signal in the cerebellar white matter, pons or basal ganglia, which may be found much before the symptoms. We have discovered that the syndrome is caused by infiltration of the brain by the BRAF or MEK mutated dendritic cells. Other therapies, when these patients fail, include the cytarabine, clofarabine, combinations of 2-CDA and Ara-C, as well as the BRAF and MEK inhibitors for all of the patients. The inhibitors are wonderful drugs which work almost uniformly in these patients, but unfortunately for high-risk patients, if you take the patients off the inhibitors, a majority of the patients will relapse. Long-term sequelae have included loss of hearing, orthopedic defects, and poor dentition, more often in those patients with very severe disease. Overall, diabetes insipidus happens to about 15% of patients, and really means that there's active disease that causes this. It's not just a late complication. It's important to note that 50% of these patients will have other pituitary deficiencies after they develop DI, and they will have MRI signs of the neurodegenerative disease. Fortunately, just a minority of them have clinical symptoms of neurodegeneration. So Retinoschisis disease is an important part of the differential lymphadenopathy and is caused by abnormalities in the macrophage lineage. It's been recently shown that mutations of RAS and BRAF and some of the other MAP kinase genes are found in some of these patients, but not all. And unfortunately, the biology of Russidorfin is really very poorly understood. Typically, these patients present with massive lymphadenopathy. They may also have skin and soft tissue nodules and growth in the nasal cavity or in the eye, causing proptosis. Interesting number of patients have also lytic lesions of the bone. They're somewhat different than those of LCH in that they're more linear and not so circular and symmetric. Rare in central nervous system and other sites have also been found in Russidorfin patients. So the diagnosis is made histologically by finding large histiocytes in which there are lymphocytes trafficking through the cytoplasm as shown here. That's a phenomenon called emperipolesis. The cells mark with CD163 and also S100 and kind of highlights those normal lymphocytes that are just swimming through the cytoplasm of these cells. Classic patient with a large cervical lymphadenopathy, some extranodal involvement, and here's proptosis caused by the Russidorfin disease, which had a nice response to clofarabine treatment. And here's a patient with lytic lesion of the talus caused by RDD. As I mentioned, the Russidorfin is part of the differential diagnosis of lymphadenopathy, of which autoimmune lymphoproliferative syndrome, malignancies, metastases, storage diseases, and other histiocytic diseases could be the cause of it. There have been no randomized trials to define the best therapy for these patients. Transient or response to steroids is often found, but when the steroids are taken away, the lymph nodes come back. So this is not always the greatest choice. Some patients can be cured with clofarabine if the lymphadenopathy is profound or if they have extranodal involvement. So a lot of the patients with classic lymphadenopathy do not require treatment for lymph node involvement alone unless there's impingement of the airway. And as I mentioned, there's treatment in a minority with clofarabine if they have life-threatening complications. Switching to JXT, this is another disease that comes from the macrophage lineage of cells and presents with large cells that stain with CD163. This is a disease that's usually limited to the skin, such as this patient here, but can lead to tumors elsewhere. And there have been patients who present with hepatosplenomegaly or progress from just a little involvement. They can also have kidney involvement, and we've seen a few patients with brain tumors from JXG. Often these are associated with NF1 mutations as well as MAP kinase mutations. So I'll switch now to the hemophagocytic syndrome, which really I think would be better known as too much inflammation. This is a disease which involves two cell lineages, the macrophage and the lymphocyte. In fact, it's the lymphocytes and HLH that are really the bad actors exciting the abnormal macrophage proliferation. It's important to note that this is a syndrome. It's not a specific disease. And in the past, 50% of patients who met criteria survived, but if they did not get treatment, less than 10% survived, and they often died very quickly. So HLH is a loss of inflammatory homeostasis, in which the lymphocytes are unable to control dendritic cell stimulation, which should normally be a limited involvement between these two cells. But in the case of the HLH, the overactive T cells lead to excessive production of interferon gamma and inflammation. And a majority of the patients early on were found to have mutations listed below, which I'll go over in a little more detail. What's happened in this these mutations are problems with a cytotoxic granule formation and injection into target cells. So normally, the cytotoxic T cell is going to inject some granzyme into the target cell, which leads to apoptosis. But in the case of HLH, these granules are either not packaged correctly or not injected correctly, so that the T cell continues to stimulate the macrophage. The genes that are have been classically associated include perforin, MUNC, syntaxin, RAB27 gene, and Griscelli syndrome, STXBP2, and then Hermansky-Pudlak syndrome. It's also known that some of gene abnormalities in parts of the immune system which control EBV infection are very important in this syndrome because of chronic EBV proliferation. So what's the epidemiology? It's relatively rare, 1 to 1.5 per 1.5 million live births, or maybe 1 per a few thousand in large pediatric hospitals. But it really depends upon the provider and the institutional culture. And the ICD-10 and 9 coding for these patients is very poorly assessed. Historically, there were 8 criteria that were used within the Histiocytic Society studies for HLH treatment to categorize patients who were eligible for this protocol. And they included fever, splenomegaly, cytopenias of 2 lines, hypertriglyceridemia or hypofibrotidynemia, hemophagocytosis, which is not all that helpful, an elevated ferritin, which rather low set point here. We find something higher is more meaningful, like over 3,000. Elevated interleukin-2 receptor levels and decreased NK cell activity. And if they didn't have all of those, if they had gene mutations, then that I just mentioned, then they were considered eligible for the protocol. But there are some updated concepts that you can check out on your own, listed in this reference. Hemophagocytosis is nice when it's found. It's obviously the macrophages are engulfing normal cells sitting in the cytoplasm, such as illustrated in these 4 pictures. But it's not always found. And there are some important parts of this syndrome which you have to remember that the 8 criteria don't include and are very often found. And those are hepatitis and liver failure, renal failure, pulmonary failure, acute respiratory distress syndrome type problem, hypotension and cardiac failure, and CNS changes, including seizures, altered mental status, abnormalities of the CSF, including pleocytosis, elevated protein, and then a inflammatory type of picture on the brain MRI. So my message to you is that if you have any of these, in addition to some of the 8 criteria, you might become even more suspicious that the patient has HLH. And historically, we've talked about familial, meaning the genetic associated HLH versus secondary. And it's really not a very helpful concept in the acute phase because you've got a patient who's very sick. So you need to treat them quickly. And it turns out that no matter whether they were ultimately found to be familial or not familial, the outcome is the same. So in the HLH 2004 protocol, we considered any HLH as HLH and need to be treated. But I think now today we need to be a little more mindful of some conditions which are similar to HLH. We call them HLH mimics versus the HLH disease. And so this is kind of a new concept, but for the test, you're still going to be thinking about familial and secondary as distinct entities. EBV is a frequent cause of HLH because the infected B cells act as a T cell irritant and drive those T cells to keep stimulating the macrophages. This is often found in the context of XLP or X-Men syndromes, but sometimes T cells can be infected by EBV and cause really a horrendous form of HLH associated with a T cell malignancy. it's been shown that T-cell infection with EBV is a little more common in Asia, but we do see it in this country also. And it's been shown that early introduction of etoposide is associated with improved outcomes in these patients. So what is secondary HLH? Well, it's often in the context of infections, malignancy, immune deficiencies, and sometimes we cause it with our CAR T cells or inhibition of some gene inhibitors. And finally, there's a group called macrophage activation syndrome found in the context of juvenile inflammatory arthritis or lupus. The macrophage activation syndrome is a condition which mimics HLH so closely that initially you can't really tell the difference. But one of the things that's become clear is that these patients have extraordinarily elevated levels of interleukin 18, often over hundreds of thousands. And often these patients also have a single mutation in perforin, MUNC, or some of the other genes that I mentioned. There's been a mouse model in which repeated TLR9 stimulation causes HLH. So I think it's the point being that any immune stimulation that's repeated can lead to HLH. So HLH can look like a lot of things, and one of the things that it often is mistaken for is Kawasaki disease because of the rash associated with this, and the onset of the cytopenias may be gradual. So again, to evaluate these patients, you're going to be looking at the CBC for the cytopenias and hemophagocytosis in the marrow, although it's not sensitive or specific. In some series, less than 50% of patients had this. Patients are going to have wildly elevated liver functions, have renal abnormalities, and you're going to look at organomegaly with various imaging panels. Look for the brain MRI and LP for CNS involvement. And it's important to look at a DIC panel, with D dimers being especially helpful. Evidence of the underlying immune deficiency is evaluated by looking at NK cell function, now using a combination of CD107 mobilization and perforin expression, and as well as targeted or whole exome sequencing. And there are more and more abnormalities, genomic abnormalities found with these patients. So it's probably best in 2021 to consider whole exome sequencing in these patients because you will find much more than the classic mutations. Essentially, any microbiologic agent can cause this disease. So it's important to look for the herpes viruses by looking at the PCR for DNA and RNA levels of these viruses. So also important to look for malignancy, as a fair number of these patients with anaplastic large cell lymphoma or T-cell lymphomas can present with HLH. And then autoimmune diseases can be at the basis also. So what we like to look at in these patients is ferritin, and it's often over 10,000. And although elevated ferritin is found in infections and in hepatitis and many other conditions, when it gets over 10,000, it becomes a lot more specific. Unregulated cytokine production is evaluated by CXCL9, which is an indicator of increased interferon gamma, which is not too well measured in the peripheral blood, but CXCL9 is. And as I mentioned, interleukin 18, the interleukin 2 receptor, TNF alpha, and then soluble 163 is a macrophage marker, which is often helpful. So when should you not diagnose a patient with HLH? Although we say lymphadenopathy happens in these patients, usually not a prominent finding. And those patients with really massive lymphadenopathy might ought to be considered more likely to have lymphoma, Castleman's disease, or some of these infections. And also, if they have massive lymphadenopathy and very elevated interleukin 2 receptors, soluble CD25, much above 20-fold above normal, and a low ferritin, that's more likely to be a patient with lymphoma. Sometimes patients who are being treated for HLH and then have a post-CNS relapse are actually patients who have an undiagnosed malignancy. And so this is something to be aware of. Normal or slightly elevated soluble CD25 and a very high ferritin, sometimes found in patients with primary immune deficiency and infections. So management treatment. Remember, this is a disease that needs to be treated quickly when you make it. And this is a syndrome which some of them are going to have the disease. So it's really one of those difficult things for us as pediatric oncologists to parse out. So what we do is, if we have a patient we suspect of having HLH, we're trending these markers that are listed here, offering supportive care and trying to limit inflammation. And if you can minimize the trigger, as some patients with herpes infections can be adequately treated and eliminate the trigger. But ultimately, you have to decide when to intervene with some of the therapies that I'm going to mention next. So the classic therapy, the standard of care, has been etoposide and decadron. And if the patients respond well, 8 weeks of therapy may be enough. Although cyclosporin was added in the 2004 trial, there was no difference in outcomes, and we prefer not to add it now because of renal and CNS toxicity. Intrathecal methotrexate and hydrocortisone are needed for those patients with CNS involvement, and that can be symptoms or evidence of the LP or the MRI changes. Sometimes if you're not sure whether the patient is HLH and you want to buy some time, giving them IVIG, plasmapheresis, or neutralizing cytokines can be helpful. And rituximab is especially helpful for patients with very elevated EBV infection. It may be added to the classic etoposide and decadron when patients with EBV HLH aren't responding well. Salvage therapy includes alemtuzumab and it's often conditioning regimen for stem cell transplant. Recently, the anti-interferon gamma antibody emapalumab has been used and is gaining favor, as well as ruxolitinib, which is currently under evaluation. Stem cell transplant is needed for a majority of these patients, and it's been found that reduced intensity conditioning provides a better outcome for those who require a transplant. So the effects of HLH in therapy are that they are increased risk of leukemia if they have a etoposide dose over 3 grams per meter squared. They have immune deficiency and infection risk, which is related to the type of therapy, whether they have a transplant or not. Often these patients have short stature and decreased fertility. So this is a quick view of the myelodysplastic, myeloproliferative, and histiocytic diseases. If you have any questions, I'm happy to answer them, and I wish you good luck on your test. Thank you. Hi, everybody.
What a great session, Ken.
I've had some great questions in the chat. I don't know, do we want to let people ask questions live and we can go back to the chat, or what's your preferred way?
We can see what questions filter in through the chat, Ken, and I'll monitor that. And we can certainly go over any of the other questions. Want to make sure that the person who asked whether or not we routinely obtain bone marrows in newborns with Down syndrome TAM, you did answer that as kind of a sub portion in a different answer, but let's go ahead and answer that just to make sure that it's clear.
Yeah, I'm sorry, I got a little bit technically challenged responding to the first chat. So yeah, for any baby with Down syndrome and proliferation of the megakaryocytes in blasts in the blood, yes, we would do a bone marrow and do cytogenetics, of course.
Perfect. We'll respond to that as well. And then we have another couple questions regarding HLH and LCH. The first question comes from Kayleen Bailey, who says, for second line LCH treatment, do you choose cytarabine plus cladribine over cytarabine plus clofarabine on the test? Any reason to choose one over the other?
Well, I think as time's gone by, we've found that the cladribine, cytarabine regimen is particularly toxic, and it is effective, and some people have actually dialed the doses down a little bit, so it's not quite as toxic and still pretty effective. But in our institution, we go from cytarabine to clofarabine because we find that if cytarabine isn't effective, clofarabine is about 80 to 90% of the time, and it's not as toxic as the combination.
All right. Thoughts about the role of CAMPATH in CNS HLH?
Yeah, it's a good question, and we haven't used that particularly because we're concerned that it won't get across the blood-brain barrier. It's a pretty big molecule, so I suspect it wouldn't be helpful, but what it would do is it would tamp down the peripheral blood T cell function and thereby decrease some of the inflammatory stimulus. So it's possible it could help, but I think that the classic intrathecal methotrexate and hydrocortisone for CNS HLH would still be considered the standard of care.
Great answer, Ken. We've got another question from Allison Close. Can you please comment on the utility of bone marrow evaluation in patients with presumed HLH when hemophagocytosis is not sensitive nor specific? So why do it, Ken?
Yeah, we still do it. I think it's sort of ingrained in us. And why we do it is not only looking for hemophagocytosis, but looking to see if there's an underlying malignancy, because you might be surprised that they've got leukemia or myelodysplastic syndrome. So I think there's good cause to do it, just realizing its limitations.
We have another question from Carolyn Hesko, who says, for single skin lesion LCH that is fully resected, would you still treat with methotrexate, vinblastine, prednisone, and HU?
No. You know, a number of these kids were fully evaluated after presenting with only skin LCH, can be watched if their rash, the surface area of their rash is modest. And if they don't have ulcerative lesions, then I just watch them for weeks and weeks and weeks. And I do see them every month and check their CBC and liver functions. But eventually, a lot of these kids will self-resolve. So no, you don't have to treat everybody.
Our next question comes from Harry. Harry asks, does the presence of monosomy 7 in pediatric MDS with blasts less than 20% mandate immediate stem cell transplant, or would you treat first with chemotherapy?
I think I'd watch them for a while to see what the progression of those blasts were and prepare to treat them, because that's a patient who really seems like they're going to need treatment, but I might not treat them in the first few weeks.
Yeah, the ability to go to transplant is not instant either. And by the time you often reevaluate, you may see that there's already subtle progression. So we're going to say monitor closely for progression. And this is certainly somebody who deserves a cancer predisposition evaluation while you're waiting.
Good point.
Got a great question from Tatiana Lara Ospina, who says, for patients with Rosy-Dorfman with symptomatic lymphadenopathy, if they failed prednisone, what's your next move?
Well, just to back up a step, I think prednisone is almost always going to fail in Rosy-Dorfman because you can achieve some diminishing of the lymph node size, but you stop the prednisone and the lymph nodes come back. So if they're symptomatic, I go to clofarabine right away. I think that's the most effective therapy for Rosy-Dorfman patients who need to be treated.
Is a lumbar puncture needed for patients with a CNS risk lesion, I'm assuming in LCH?
That's a good question. We talk about CNS risk. So what's the risk? Well, no, we have not routinely done lumbar punctures in these patients. Because we did for a while. We had a study and we were looking for evidence of a marker of LCH, osteopontin, which is the most highly upregulated gene. And we never found a level that was really diagnostic, and we couldn't really get any help from the spinal tap. And also, we've never found BRAF mutated cells in the spinal fluid of patients unless they have spinal cord involvement. So we don't typically do lumbar punctures.
We've got a question from Eman Abdul Ghani, who says, I'm a little confused with the HLH terminology. Is HLH disease the equivalent of primary HLH / familial HLH, and HLH mimics, are those equal to secondary HLH?
Yeah, it's terribly confusing. It's hard to parse that for you exactly. I think it kind of goes that direction. The HLH mimics are secondary, but that's the problem with the whole terminology for HLH, is trying to make it very exact. And I think HLH or inflammation associated with X is maybe a better way to think of this disease. It's a hard question to answer very precisely. I'm sorry I'm not doing a great job for you, but I see where you're going with it. And in a sense, I agree with you. It kind of is that way, as you stated.
Our next question comes from an anonymous attendee who asks, could peripheral blood cytogenetics replace doing a bone marrow for Down syndrome TAM patients, or could you expand on why the bone marrow is required / recommended?
Well, I think the bone marrow helps you for morphology and for looking for the mutation. But your point is well taken, that you could, with the amount of blasts in the peripheral blood, you could do the mutation analysis and determine if they had additional cytogenetic abnormalities. So I think your point is well taken. I guess it's helpful to know at baseline if there's a lot of fibrosis and how much damage there is to the hematopoietic system.
Looks like we've had a brief pause in the questions coming in.
I could flesh out one of the questions a little more. Someone asked a very good question about when to use the BRAF inhibitors and when would they be used. And my answer, or would you use them up front? That was the question. And so I personally don't use them up front because I think that I believe, risky to use these kind of drugs for long periods of time in young children when we don't know the long-term side effects of them. And the very dirty truth is that 50 or more % of patients who have the BRAF mutation will relapse when you take them off the inhibitors. So that doesn't sound any better than vinblastine and prednisone. And you get tremendous clinical responses in kids with bad liver disease who aren't responding to cytarabine or even clofarabine. Sometimes can have magical responses, miraculous responses to inhibitors. And then you get them cooled down, and then you can get rid of the clone with classic chemotherapy. And that's the big conundrum in the field right now, is that we're searching for ways to get rid of these persistent clones. And we haven't come up with a magic answer yet. We have some basic science hints about what we should do, but we haven't achieved the goal.
And now we have a new question from Noura El-Hajj. Not a board question, but there are some European data suggesting the use of single agent indomethacin for LCH, multifocal bone disease. What's your thought on that in your practice?
Yeah, that's been around for 20 or 30 years. And indomethacin reduces inflammation. And if a lesion is mainly driven by inflammation, such as single bone lesions or skin, I mean, I can see sort of the theoretical value of it. Personally, I've never used it, and I don't find it that the data supporting the use of it is very unconvincing, because the majority of the patients in these papers were pre-treated with something else. They had surgery. So, there's spontaneous resolution of single bone lesions. I think it's very controversial. I'll just leave it at that.
Yeah. Jenna Allison asks, I have a couple of patients who had TAM with blasts self-resolving in 1 to 2 months, who now have elevated LFTs about a year or more out. I sent them to GI for an evaluation, but I'm curious if there's any relationship to their TAM. She couldn't find anything in the literature, but have you seen anything like that?
Yeah, that happens because of those patients with massive splenomegaly, I mean hepatomegaly and fibrosis in the liver, and I think it's a long-term effect of the blasts and causing almost a cirrhosis type pattern.
We have time for maybe just one or two more questions. There was also a question that was asked in the chat that we had also tabled for discussion, and that was regarding the monitoring of patients with JMML. I can actually weigh in a little bit on that. So in the cancer predisposition program, there are some high risk PTPN11 mutations where the child has had, where there's been documented malignancy associated with that. Those patients, we typically offer a quarterly CBC up until the age of 5. If there has not really been a documented case of leukemia associated with a patient's particular genetic mutation, then you don't have to necessarily follow them with routine CBCs.
Seems reasonable.
And we have 2 more questions. We're going to try and dial down and answer them. For Priscilla Badia, is there any indication of lymph node surgical resection for Rosai Dorfman? This was a board question.
I would only do that if there were airway or other abnormal, dangers from the. But the general answer is no. I think you can cause more trouble with extensive surgeries in the neck area.
And then we'll say our last question for the day is from Carolyn Haskell. She says, besides at birth or 1 month of age, are serial CBCs needed or recommended in patients with Down syndrome? And is that needed in Down syndrome with TAM?
Yeah, I think that they should have serial CBCs.
Yes, particularly patients with Down syndrome TAM for sure. Fantastic, everybody. Ken, it's always really nice to see you and great to hear you speak. This has been a wonderful lecture. For everybody else, we're going to close down the chat function. Don't forget, after this is the meet and greet, the social hour. That is pretty much right after this in the next Zoom room. So please stop by and network with your friends and other colleagues. Tomorrow, we're going to start the next session promptly at 9:30 Central Time. So don't forget to be there with bells on. Thanks so much for joining us in the ASPHO review course. We will be letting you know our office hours shortly. Have a great night, everybody.
Thank you for all your good questions. Bye-bye.